In blunt trauma to the chest, the pulmonary contusion part is being managed now by getting a chest X-ray confirming your diagnosis. And you want to confirm your diagnosis before you decide upon intubating this patient, because you have two differentials on somebody with fracture of the rib who presents with deteriorating of his pulmonary functions. Number one is pulmonary contusion. Number two, patient may have a pneumothorax. Now, I asked a question to the students that is it necessary to have that differential and diagnose whether it is pulmonary contusion or pneumothorax before you intubate the patient if there's a minor pneumothorax? Does it matter? Does it matter if patient has a minor pneumothorax associated with pulmonary contusion? Patient needs to be intubated anyway. Why don't you just go ahead and intubate this patient? Would you agree with that plan? Well, many people did agree with that plan. So if they advise me to do that, then I'm going to take you through the case scenario of that wrong decision. I intubated the patient because my patient had mainly pulmonary contusion and a very minor, small, simple pneumothorax. Guess what? I intubated the patient and put the patient on the blower. Within 10 minutes, the nurse calls me back and tells me that your patient is collapsed. His blood pressure is 60/20, and his neck veins and forehead veins are engorged. The patient is not responding to my fluid challenge. I don't know what's happening here, doc. Give me the diagnosis. Your simple minor pneumothorax became a major tension pneumothorax, which is becoming life-threatening. Before you know it, before you arrive to save him, he could very well expire from this mistake. All right? So a minor pneumothorax, which is clinically occult, may become a significant factor in the management of such cases. So for the boards, get a chest X-ray first before you intubate. Now, you got a chest X-ray and there's a 10% apical pneumothorax, but there's pulmonary contusion and the patient requires intubation. So what's the first thing you're going to do? Put a chest tube in first, cover your pneumothorax, then intubate the patient. So I told you earlier on that I'm going to give you the principles of managing a tension pneumothorax, and you're going to fall trap to questions the way they are asked. Okay? No anesthetist in this entire world would ever intubate any patient with a pneumothorax without a chest tube in place, even if it's a minor pneumothorax. And we'll talk about minor and major pneumothorax in a little while. The management of pulmonary contusion then is, the patient needs to be on positive pressure ventilation. Keep the pressures low. Do not give too much of tidal volume, because you can blow a hole in a contused lung. A contused or a damaged lung can easily be damaged by barotrauma of the ventilator. Ventilator is not a physiological system. Ventilators are not physiological. This is unphysiological type of breathing. It's a breathing that is needed because the patient, there's no other way to make the patient survive through his injury. So it's non-physiological system, high pressure system. So you need to keep the pressures as low as possible. As low as possible. Okay, so the tidal volume should be low and the PEEPs should be around 5 and the patient should be in a relative state of dryness. Do not give injudicious fluid challenges or fluid therapy to this old man with a contused lung. The contused lung has a propensity to extravasate fluid within it and makes matters worse. So keep the patient on an IV drip going at a reasonably appropriate rate, but not be over-aggressive with fluid therapy. The outcome of pulmonary contusion is best described by which one of the following statements? Number one, most of the pulmonary contusion is self-limiting and resolves completely without any evidence of scarring within a matter of few days. Number two, pulmonary contusions generally progress to develop pneumonias and complications. Number three, pulmonary contusions involve necessity to operative interventions. Number four, pulmonary contusions mostly resolve with some degree of fibrosis, which is the majority of pulmonary contusions are self-limiting within a matter of few days on supportive management alone. They do not lead to any long-term sequelae like scars, fibrosis or loss of lung parenchyma. Okay? That is your complete management of pulmonary contusion. After 4 or 5 days, this patient will do fine. His chest X-rays will look fine. His blood gases will return to normal. You can wean him off the ventilator, extubate him, and then he'll be fine. All right. Another case scenario. Patient is a 55-year-old female who had a road traffic accident. She is brought in from the scene of the accident complaining of pain in her left side as she had a right-sided impact by another car to her car, and her left side of the chest basically crashed against the side door as she was the driver of the car. Okay? A chest X-ray was done which showed fractures of multiple ribs at more than 2 points. On physical examination, you notice that each time the patient will take an inspiration, her chest wall on the left side would suck in. And each time the patient would expire, the chest wall is going to blow out. So she is showing paradoxical respiration. What is the diagnosis? Flared chest. By definition, more than 2 ribs broken at 2 or more points, leading to jeopardization of the patient's ventilatory efforts. It's called paradoxical respiration. That flare segment moves in and out in contrast to the rest of the respiratory apparatus, leading to respiratory compromise. The right appropriate management of a progressively deteriorating patient with flared chest is, number 1, put straps of tape around the left chest to secure and stabilize the flare segment. Number 2, patient should be given intercostal nerve blocks and encourage deep inspiratory efforts. Number 3, patient should be taken to OR for open reduction and internal fixation of the fractured ribs. And number 4, patient should be put on a ventilator with peak inspiratory pressures with PEEPs of 5 or more as required for oxygenation. Number 1, that is, put a strap of tape around the chest to stabilize the flare segment. Yeah, it's very typical of doing things the old-fashioned way. That is just about not the answer you will choose for the boards in the United States. Putting a splint to stabilize your flare segment is a 1950s practice. Half a century ago, the physicians used to do that. And this is not encouraged anymore because it doesn't work, number 1, and it encourages hypostatic pneumonias. The treatment for flare segment is, if the patient is clinically deteriorating, becoming hypoxic and hypercarbic and tachypnic, the right treatment is to intubate the patient and put him on a positive pressure ventilation. The positive pressure, the PEEP, is going to stabilize your segment. And after 48 to 72 hours, the flare segment stabilizes on a ventilator. And then you can wean the patient off once the flare segment is stabilized. The flare segment is just not a mechanical problem. There's an underlying pulmonary contusion associated with this, because the degree of injury and the force which has resulted on this chest is very high. So they have pulmonary contusion too. So you're killing 2 birds with 1 stone by doing a ventilation. You're going to take care of her hypoxemia and you're going to take care of her hypercarbia, both. Hypercarbia is a result of flare segment and hypoxemia is a result of underlying pulmonary contusion. Contused lungs cause hypoxemia. Flare segments cause hypercarbia. There's a type 1 and a type 2 respiratory failure coexisting in flare segment. And they love to ask this question because it judges your knowledge at both levels. Okay? Still first test is what? Yes, absolutely. If the short of a tension pneumothorax, if the patient is hemodynamically stable, you must get a chest X-ray. You must get a chest X-ray, short of a tension pneumothorax or other immediate airway problems. Yes, ma'am. Simple rib fracture, as I mentioned in my first scenario before, intercostal nerve block, chest physiotherapy, close observation on a monitor. If the patient does well, he goes home after 3 or 4 days. Okay, that's a simple rib fracture. But my patient was not simple. His simple rib fracture got compounded by pulmonary contusion. That's why we talked about that. And now we have a complicated rib fracture, the flail segment, which is requiring intubation. And this flail segment is a combination of both, a flail segment and an underlying pulmonary contusion. All right. Now, moving forward to another case scenario here. Patient is a victim of a road traffic accident. He had a head-on collision and he was brought in to the emergency room complaining of pain in the right side of his chest. After performing his primary survey, you notice that his main complaint is the right-sided chest pain. On auscultation, you don't hear any breath sounds. And on percussion of the right chest, you have a dull percussion note. What is the next appropriate step in the management of this patient's condition? Number 1, a chest CT. Number 2, a chest X-ray. Number 3, an ultrasound of the chest. Number 4, do an intercostal tube insertion in the right hemithorax. Patient is hemodynamically stable. Chest X-ray. Good. Chest X-ray was done, which shows a whiteout of the right hemithorax. The next appropriate step in the management is, number 1, insertion of the intercostal tube in the right hemithorax. Number 2, patient should have aspiration, diagnostic aspiration of the right hemithorax. Number 3, patient should have an angiogram. Number 4, patient should be taken to the OR for exploration of the right hemithorax. Chest tube is the right response. This is the diagnosis of hemothorax, not pneumothorax. A chest tube was inserted. Which of the following is the correct statement? Number 1, after the insertion of chest tube, if the drainage of the blood from the hemithorax is more than 1500 cc's with the presence of persistent hypotension, it's a requirement for a thoracotomy. Number 2, blood drainage of less than 100 cc's an hour for the next 6 hours is an indication for thoracotomy. Number 3, minor hemithoraces arise from the pulmonary vasculature damage. Number 4, major hemithoraces arise from the pulmonary vasculature damage. Which one of these is the most appropriate response? The more than 1500 in the face of persistent hypertension requires thoracotomy. Minor hemithorax, meaning less than 400 or 500 cc's of blood available in the 24-hour period from a chest drain, is usually the result of pulmonary circulatory damage. That is also true. But the most appropriate answer here in the management of hemithorax is you should know when to do a thoracotomy. And your best response is going to be thoracotomy for more than 1500. More than 1500 on insertion. The moment you insert the chest tube, you deliver a blood flow of 1 liter and 500 cc's of blood, and the patient is hypotensive in spite of your resuscitation going on. This is an indication that the blood in the chest is coming from, I give you the choices, aorta, main pulmonary artery, intercostal artery, or a branch of pulmonary artery. Such a huge amount of blood loss into the pleural space. Is it coming from the aorta? Is it coming from the main pulmonary artery? Is it coming from the minor pulmonary artery? Or is it coming from the intercostal artery? The most common source of active bleeding in the pleural space is from where? Aorta? People who rupture their aorta into the pleural space, they don't make it to us. They make it to the funeral home. They don't make it to us. They die. They never make it. So if you see a massive hemothorax in a trauma victim, the most likely source is intercostal artery. That produces a major bleed, and a minor bleed, which is less than 500 cc's over 24 hours, is usually from the pulmonary artery. Pulmonary artery bleeds because there's a fracture of the rib. It goes inside the chest and it lacerates the pulmonary parenchyma, leading to pneumothorax or hemothorax or a combination of pneumothorax. Those are minor bleeds and they stop on their own without further intervention. But a major bleed comes from the intercostal arteries, and by and large, it is massive. It's enough because intercostal artery is a branch of the aorta. And it's high pressure system. And they bleed in the low pressure system. What is the low pressure chamber? Pleural space, negative intrathoracic pressure, negative atmospheric pressure. High pressure bleed being accommodated in a huge negative chamber. Right? So there's enough amount of blood that can accumulate there, and that requires drainage. Now, there are 3 criteria for doing a thoracotomy for hemothorax. Number 1, you deliver or you drain 1,500 or more of blood on the moment you insert the chest tube in the face of hypotension. If the patient stabilizes, then you observe. You have to have a combination of clinical signs and your drainage. You do not, in isolation work, you do not say 1,500 cc's came out, patient is hemodynamically stable, he has responded to your IV fluid therapy, his blood pressure is 120/70, his pulse rate is 85, he's looking comfortable. Just because he has 1,500 cc's of blood doesn't mean you need to do a thoracotomy. You have to have an association between the vital signs of the patient and the drainage amount. That's the principle. So 1,500 cc's or more, patient is continuously hypotensive, continuously tachycardic on your resuscitation. Indications for thoracotomy. It's the intercostal artery that's bleeding, you need to ligate it. Number 2, patient is draining more than 250 cc's of blood per hour for the next 4 hours. That's another indication for going to the OR for thoracotomy. And number 3, if the patient has drained more than 2.5 liters of blood over 24 hours, that's also an indication. So there are 3 indications. 1,500 or more on the spot, hemodynamically unstable in spite of resuscitation. Number 2, 250 cc's per hour for 4 consecutive hours goes to the OR. Number 3, more than 2.5 liters in a day goes to the OR. 3 indications for thoracotomy. Otherwise, put a chest tube in, drain the patient, that's the end of the treatment. Now, is it necessary to drain a hemothorax? Why can't you just leave it? When you know that the hemothorax that is small or minor hemothorax, majority of these are self-limiting, they will not bleed any further and they will stop bleeding. So why do you need to drain those? If it's a total white out of the lung, fine. If it's a small amount of hemothorax at the base, like 500, 600 cc's of blood, it is going to disappear. Just leave it there. Is there a problem? Is there a problem in missing a hemothorax and not draining it? Yes. A hemothorax is free blood in the pleural space. You can develop secondary infection. It will become empyema. It will lead to fibrothorax and it will lead to loss of pulmonary parenchyma, a vital organ of the body. You're going to trap his lungs in the fibrosis from scarring in the pleural space. And once you trap his lung, he has lost his pulmonary alveolar function. All right? Next case scenario in the chest trauma. Patient is a 15-year-old boy who was riding his bicycle. As he traveled down the road, he tipped over a stone and fell to the pavement. He landed on the left side of his chest, injuring the left side of his chest as he landed on a concrete pavement. Patient was brought to the emergency room, awake, alert, oriented, and talking appropriately in a normal voice. His blood pressure was 120/80, his respiratory rate was 20, and his pulse rate was 100. On arrival after his primary survey, you notice that on secondary survey, his abdomen is a little bit tender in the left upper quadrant. You notice grazes in the left hemithorax lower down in the chest, over the 9th, 10th, and the 11th ribs. How clear can I get? Patient has some dullness to percussion at the base of the left lungs. and a chest X-ray was appropriately ordered and showed fracture of the 9th, 10th, and 11th ribs in the left hemithorax with small amount of pleural effusion. Very small amount of pleural effusion. The next appropriate step, at the same time the chest X-ray shows that the patient has an apical pneumothorax in the left hemithorax. The next appropriate step in the management of this patient's condition is, number 1, take the patient to the OR for exploratory laparotomy as the patient has a very high suspicion for splenic trauma. Number 2, patient should have a diagnostic peritoneal lavage before rushing him to the operating room for exploratory laparotomy. Number 3, patient should have a CT scan of the abdomen to evaluate his blunt abdominal trauma. Number 4, patient should be given ultrasound of the abdomen to identify the source of his left upper quadrant pain. What is the best response? DPL, CT scan, ultrasound, directly to the OR, observe without any further investigations. Patient is stable, hemodynamically okay, no big deal. Ultrasound, see, all the questions and all the responses coming from everywhere. But there's only one best. And that's what you have to pick up. The best response is, this is a blunt chest and abdominal trauma combined. And the patient is hemodynamically stable. He has fracture of the left lower ribs. Your best response is going to be CT scan of the abdomen. CT scan has now become the gold standard for evaluating blunt abdominal trauma. It's the gold standard for evaluating blunt abdominal trauma. But there's a big but. The patient should be hemodynamically stable. The patient should be hemodynamically stable. That is the big condition with it. Now, a CT scan was done and it showed there's a 5 centimeter subcapsular hematoma of the spleen and a very small amount of free fluid in the peritoneal cavity. The next appropriate step in the management of this patient is, number 1, patient should be taken to OR for semi-elective splenectomy. Number 2, patient should be taken to the angiographic suite for angiographic embolization of the splenic artery. Number 3, patient should have a laparoscopic removal of the spleen. Number 4, patient should be admitted to closed monitored setting for repeated clinical examinations and hematocrit evaluations. Number 4, it's a contained hematoma of the spleen. Not all hematomas of the spleen require removal. If the patient is hemodynamically stable, CT scan is done, it confirms the diagnosis and shows you that the spleen is got a contained hematoma with no free fluid in the peritoneal cavity and the patient is hemodynamically all right. You can observe him closely with serial abdominal examinations and if necessary, serial CT scans to see whether the hematoma is increasing or decreasing in size. After 24 hours of admission, the nurse calls you. This is step 3, questions coming one after the other. After 24 hours of admission of this boy, the nurse calls you and tells you that your patient is not doing well, doctor. His blood pressure has dropped to 90/60. His pulse rate has gone up to 120. And his hematocrit was done 10 minutes ago, which shows a drop from 35 to 22. His abdomen on examination is distended and tense. He has tenderness all over. The next appropriate step in the management of this patient, DPL, ultrasound, CT scan of the chest and abdomen, and number 4, rush to the OR for exploratory laparotomy now. I heard DPLs. Who's going to do DPL here? What do you want to know that you don't know already? What has happened to this guy? What is a natural course of a subcapsular hematoma of the spleen? 2. 1, self-contained, stable, and resolution. 2, dissection and further dissection till it lacerates the capsule and ruptures freely. What happened to this boy? The subcapsular hematoma remained contained or ruptured? It ruptured. So he's now presented with hypovolemic shock. He's hypotensive, he's tachycardic, he's dropped his hematocrit, his abdomen is distended, it's tense, it's tender. What do you want to know? Why are you doing a DPL? Why are you repeating a CT scan? You know the diagnosis. You have a patient who is hemodynamically unstable. You can't do a CT scan who is hemodynamically unstable. The patient was rushed to the operating room. What is the next appropriate step in the management of this patient's condition? Number one, put a chest tube in the left hemithorax and intubate the patient before exploration. Number two, patient should be intubated immediately for exploration because he is hemodynamically unstable. Number three, it is a good idea to take the patient to the angio suite for angiographic embolization of the splenic artery to control the hemorrhage first. Number four, patient should be given blood products like packed red cells and fresh frozen plasma to correct his coagulopathy before exploration. Intubate in the OR. What is the best answer? The best answer here is to intubate the patient in the operating room. But before you intubate your patient, one single, most important precaution is to insert the chest tube first. Remember, this child had a 10% apical pneumothorax when he came in. So, pneumothoraces, which are less than 20%, they can be observed and they do not require drainage because they are self-limiting and they resorb on their own in a matter of few days. However, if you are planning to intervene on this patient for other reasons and you're going to put this patient on a positive pressure ventilation in the OR for other injuries, that simple pneumothorax should not be ignored. Because if you intubate this patient without a chest tube, this patient is going to get a tension pneumothorax. So a simple pneumothorax will be converted into a tension pneumothorax the moment the patient is connected to a ventilator. So always drain the chest before you intubate in cases of any pneumothorax. Any. Any means even a minor one. Okay? Say, for instance, a chest X-ray did not show any pneumothorax. Sometimes the pneumothorax can be so small that even a plain X-ray of the chest will not show it. You can sometimes only see pneumothoraces on a CT scan of the chest. And in such situations, if you happen to take the patient to OR without knowing that the patient has pneumothorax, it was occult to your radiological investigation, and you put the patient to sleep and you intubate your patient, and while you're merrily operating, the anesthesiologist tells you that it's hard to ventilate my patient, that I have to disconnect him from the machine and I'm manually compressing on the bag so that I can get some air in. And the air is becoming harder for me to intubate, to ventilate him. And secondly, I also noticed that his blood pressure has dropped suddenly from normal tension to 60/20. Are you bleeding? He's going to ask you. Are you bleeding? And you say, no, bleeding is under control. So there's no active bleeding. Patient becomes hypotensive and it's difficult to ventilate the patient. What is the appropriate step here in the management of this patient's condition? Needle, chest tube. Needle, chest tube. Ask the surgeon to put a chest tube. So the surgeon's going to come out and take out the drapes and put a chest tube. It'll take about 10 minutes. Patient is gone. Neck veins are distended, guys. Head veins are distended. It's tension pneumothorax. A needle or a chest tube or something else. When the patient is doing a laparotomy, when the surgeon is doing a laparotomy for a ruptured spleen and an occult pneumothorax was missed and has not developed a tension pneumothorax, the best thing to do is, when you suspect the scenario, look at the scenario. Blood pressure is down, neck veins are distended, and this patient has what, for all practical purposes, tension pneumothorax. Then the thing to see is to look at the diaphragm. If it is a tension pneumothorax, the diaphragm will be ballooning into the abdomen. Diaphragm never balloons into the abdomen. If it balloons into the abdomen, you know that there is a lot of air in the hemothorax. Easiest and fastest way to do is to puncture the diaphragm from the abdomen and let the air out through the abdomen. and save the life of your patient. Did anyone think about that? You did? Why didn't you tell me? You weren't sure? Really? Good. Thank you. Excellent. Okay. Right. He must be a surgeon. All right. So the whole idea is to be aware of pneumothoraces. They can be missed and they can become life-threatening very soon before you even know it. All right. Now, and the thing is this, that when you have a ruptured spleen, it has to go to the OR. And then post-splenectomy, you know that the patient needs a couple of things. Post-splenectomy, a patient becomes rendered for high risk for OPS, O-P-S-S. What is OPS? O-P-S-S. Overwhelming post-splenectomy sepsis. It happens in 1% of the people, but the mortality is very, very high once it happens. It's the capsulated organisms like pneumococcus, meningococcus, Haemophilus influenzae that do not get easily destroyed by our neutrophils and macrophages. They need to be opsonized, and the way they are done, it is done in the bodies by spleen. Once the spleen is out, the opsonization of bacteria with capsules is gone. And these can multiply within the body without any resistance to them from the normal army of the body, the WBCs. And eventually they overtake and kill the patient. And in such situations, whenever you do a splenectomy, if the board is asking about post-splenectomy management of a patient, do not forget to give them Pneumovac and Hemovac. Sometimes you can give them. I think there's Pneumovac is the standard vaccine that you have to give them. And you have to advise them whenever they present with signs of flu-like symptoms. Whenever they have flu-like symptoms, it's a sign of overwhelming post-splenectomy sepsis, unless until proved otherwise. They should be hospitalized. They should be given large doses of penicillin to take care of the problem. Remember that. Overwhelming. I am overwhelmed. That is what it is. Overwhelming. Overwhelming post-splenectomy sepsis. Okay? Now moving on to another possible chest trauma case. Well, we've done chest mainly. Now we're going to talk about another case scenario before we move out from chest and go to the abdomen. We've already done part of the abdomen. But here you go, another scenario. A 40-year-old female driving at 50 miles an hour gets a head-on collision, was wearing a seat belt, but her chest struck against the steering wheel. She comes to the emergency room, awake, alert, and oriented. Blood pressure is 120/70 and pulse rate is 100. She says that she has got intense pain in her chest. Her primary survey was complete and did not show any immediate life-threatening conditions. Her secondary survey involved getting a chest X-ray, and it showed that the patient had an undisplaced fracture of the sternum. The next appropriate step in the management of this patient's condition is take the patient to the OR for open reduction and internal fixation of the chest for the sternal fracture. Number 2, patient should be admitted to a cardiac monitor setup for 24-hour to 48-hour observation, including serial EKGs and serial cardiac enzymes. Number 3, patient should be sent home on narcotic analgesia with follow-up in the clinic in 1 week. Number 4, patient should have a transesophageal echo to rule out pericardial effusion. Number 4 sounds good, huh? Sounds relevant, sounds close to your suspicion. What is your suspicion in this injury? It is cardiac contusion. Fracture of the sternum is not of consequence. It is a telltale sign that the force was very strong, and it's not only the sternum that has been broken, it must have injured what is underneath the sternum. Which chamber of the heart is in contact with the sternum? Right ventricle. So the right ventricle gets bruised and contused, and that can lead to Problems? Yes. What is the most common complication of cardiac contusion? Arrhythmias. What are the most common types of arrhythmias associated with cardiac contusion? Supraventricular or ventricular? Supraventricular. Supraventricular arrhythmias are more common, but ventricular arrhythmias are more lethal. They kill. Many patients die on the scene once they go into VTAC and never be recovered. So that's number one complication of cardiac contusion, arrhythmias. So you admit them, you observe them, you do EKGs, and you send for cardiac enzymes. Which cardiac enzyme has the most sensitivity in diagnosing cardiac contusion? Troponins nowadays is an answer. It's better than CKMB. Troponins are almost, there's a body of literature accumulating talking about troponin being extremely sensitive and specific for cardiac contusion in appropriate clinical setting. Sorry? IOT? What is IOT? I don't know. Troponins is all I know about. Okay? Now, the second thing you have to know about is, number one is arrhythmias, and number two complication is pericardial effusion, which basically means there's a laceration to the pericardium, and soon the patient can go into cardiac tamponade and die. So you have to be aware of that, for which you do an echo. Number three complication that can happen is what? Rupture, free rupture. And then there are long-term complications. One of them is aneurysm of the ventricle, and two is chronic arrhythmias. So cardiac contusion, most of the time, may be self-limiting without any long-term sequelae or short-term sequelae. But there is a proportion of cardiac contusions that can go into acute or long-term complications, and you must be aware of them. And every single cardiac contusion needs to be admitted to the hospital and observed on a monitored setting for 24 to 48 hours to rule out arrhythmias and to rule out pericardial effusions. And then if the patient remains stable, then he can go home. So the right response from my question was, admit to the hospital on a coronary monitor and serial EKG and cardiac enzymes. Echo will be done as a specific investigation if you're suspecting effusion, if you're suspecting tamponade, but not routinely. That's not the reason. That's not the best answer. That's not the best answer. The best answer is admit, observe 24 hours on a monitor with EKGs and serial enzymes. Okay? Arrhythmias, effusion, rupture, acute, chronic arrhythmias, and ventricular aneurysms. Okay? Now moving on to the abdomen now. We are still on trauma, guys. And we'll finish abdomen and pelvis in the next 15 minutes before we take a break. We've already done blunt abdominal trauma. Now we know if the patient is hemodynamically stable with history of blunt abdominal trauma, the gold standard for diagnosing is CT scan. The question is, when do you do a diagnostic peritoneal lavage? A case scenario is there for your health. Number one, patient is a 25-year-old who had a road traffic accident, brought to the emergency room, was found to be confused, agitated, and restless. Patient was smelling of alcohol from his breath. Patient had injuries to the femur, which appeared to be an open fracture of the femur. The orthopedics surgeons wants to take the patient to the OR as soon as possible for open fracture of the femur. His abdominal examination is equivocal. He has some degree of tenderness, however the abdomen is not distended. You are not sure whether the patient has an intra-abdominal injury or not. His blood pressure is borderline 90/60 and his pulse rate is 100 while he is being resuscitated. An ultrasound in the emergency department is not clear whether there is free blood in the peritoneal cavity or not. The next appropriate step in the management of this patient's condition is do a CT scan to rule out blunt abdominal injury prior to taking the patient to OR for fracture repair. Number 2, patient should have a diagnostic peritoneal lavage. Number 3, patient should have a mini laparotomy in the operating room while the orthopedic procedure is being conducted. And number 4, patient should be elected to be observed closely after the surgery to rule out intra-abdominal hemorrhage. No, this patient has got, there's a scenario here. This patient has an abdominal examination which is not very clear-cut. His ultrasound is not very helpful. There is a reason to believe that he may have blunt abdominal trauma and some degree of blood loss inside his abdomen. But there's also an emergency orthopedic procedure that needs to be done as soon as possible. And post-operatively, he may remain under the influence of anesthesia for a long time to make his abdominal examination reliable. So number 1 the answer here is to do a diagnostic peritoneal lavage. And the indication number 1 for diagnostic peritoneal lavage is when you have a patient who is either intoxicated or unconscious or has spinal transection, so he cannot feel any pain when you examine his abdomen. So an equivocal abdominal examination in the face of a good history of blunt abdominal trauma. You're suspecting blunt abdominal trauma, but the patient has an equivocal abdominal examination because of intoxication or because of unconsciousness or because of the spinal cord transection. Intoxication, unconsciousness, spinal cord transection are the three common scenarios where you get a confusing picture, an abdomen that cannot be evaluated appropriately. And patient needs to go to the OR for either an orthopedic injury or neurosurgical emergency. And you can't wait, you can't take the patient for the CT scan. In such situations, doing a DPL is the right thing to do. What is a positive DPL? Sometimes they give you values. Red blood cells, 100,000 per cubic millimeter of the fluid aspirated. White blood cells, 500 per cubic millimeter of the fluid aspirated. 3, presence of bile, fecal matter, or vegetable material. Those are the 3 criteria for a positive DPL. Red blood cells of 100,000, white blood cells of 500, presence of bile, fecal matter, or food particles. Apart from these 3, if I do a DPL on somebody and while I am doing a DPL, I aspirate 10 cc's of frank, fresh blood, what does it mean? That's also positive DPL. You don't need to proceed with complete DPL. You stop there, patient goes to OR without further delay. Okay, so there are 4 criteria that tell you the DPL is positive for exploration. So we discussed the blunt abdominal trauma, role of CT scan, and role of DPL, and they are all tested in the exam. The next thing that you need to remember, and actually this is covering more than one cases. I think we have covered now 4 cases in your notes already here. The next case is penetrating abdominal trauma. Penetrating is 2, stabs and gunshot wounds. They both can present with peritonitis. The principles of penetrating abdominal trauma are, irrespective of the way the trauma took place, stab wound or gunshot wound, if the patient is hemodynamically unstable and patient has gross signs of peritonitis, he goes to the OR. There is no question about it. All gunshot wounds to the abdomen go to the operating room because they are by definition high velocity injuries. And even if they're clinically stable, that does not mean that there is no injury inside. It's mandatory to explore all gunshot wounds. it is mandatory to explore all stab wounds to the abdomen with clinical evidence of injury, like peritonitis or patient's blood pressure is down in the boots. Somebody gets stabbed, he's hypotensive, he's got distended abdomen, he goes to OR, no question about it. So all gunshot wounds and all stab wounds with obvious injuries need to go to the OR without further delay. There is no role of CT scan or DPL in penetrating trauma. The debate about CT scan being the king of investigations is purely on a blunt trauma. In a penetrating trauma, we don't do CT scans as a rule for your step 3. Remember that. So penetrating trauma, by and large, the gunshot wounds and the stab wounds with obvious clinical signs and symptoms of peritonitis or hemodynamic instability goes to the OR. But the stab wound that comes like this to the ER, I want you to tell me what would you do with this guy. He's a gang member, 25-year-old, who comes to the emergency room walking himself, saying he was stabbed outside the hospital. On examination, he's awake, he's alert, he's oriented. He is appropriate, and he is cursing, obviously. And on examination, he has a wound on the right side of his umbilicus, which is about 2 centimeters in size. There's some amount of bleeding from that wound. His abdomen is completely soft and non-tender. His vital signs are stable. And you do not see any evidence of peritonitis or any evidence of gut or evisceration. What is the next appropriate step in the management of this patient's condition? Number 1, a DPL. Number 2, a CT scan. Number 3, an ultrasound of the abdomen. Number 4, local exploration of the abdomen in the ER. And number 5, patient should have a laparoscopic exploration of the abdomen. The correct answer is local exploration of the abdominal wound from stab with no evidence of clinical peritonitis or hemodynamic problems. If there's a stable stab wound with no obvious peritonitis or no obvious evisceration, this patient needs a local anesthesia in the ER on the gurney and opening up of the wound and digital exploration to identify a breach of the peritoneum or not. That's what you need to see. You need to see whether the peritoneum is breached or not. If the peritoneum is breached, patient goes to the OR. If the peritoneum is intact, close the wound and patient can go home. A breached peritoneum is associated with 30% missed injuries in the abdomen. Although there's no peritonitis, there's no bleeding, 30% of the peritoneal breach is associated with positive laparotomy. 70% are negative. So for those 30%, you have to open every single patient. And that's the accepted standard right now. It may change in a few years, but right now, that's what we do. All right? Yeah. 30%, if you explore, a patient has got no peritonitis, absolutely stable. He's got an abdominal wound by a stab, which was explored by you, and you find that the peritoneum is breached. When you take a population of these patients and explore them in the OR routinely, only 30% of them will have internal injuries from that stab wound. 70% will not. However, that is the standard for your USMLE Step 3. All stab wounds penetrating the peritoneum must be explored for your Step 3. All stab wounds with penetration of the peritoneum must be explored, even if clinically they are fine. Okay? We take a 5 minutes break, and then we do pelvic injuries, and we move on with other case scenarios. Patient is a 25-year-old motorbiker who was hit from the back by a trunk, and he flew off to about 25 feet and landed to a hard concrete sidewalk. He was brought to the emergency room, awake, alert, oriented. Vital signs show a blood pressure of 90/60, pulse rate of 120, respiratory rate of 25, He's saturating 90% on room air. He's combative and agitated. However, patient is asking for water. He feels thirsty and he feels cold and he asks for a warm blanket. His abdominal examination shows some degree of distension in the lower abdomen. However, his extremities appear intact except for some superficial bruising in the perineum and around the scrotum. The next appropriate step in the management of this patient's condition is, number 1, inspect the oropharynx and remove any foreign bodies. Number 2, patient should have 2 large bore IV cannulas and infusion of ringer lactate through each line. Number 3, patient should have endotracheal intubation immediately. Number 4, patient should get an X-ray of the cervical spine, chest and pelvis as the next step in the management. And number 5, patient should have a diagnostic peritoneal lavage to evaluate the cause of his hypovolemic shock. Same case scenario, guys. The airway is first. You need to open up his mouth, make sure he doesn't have any foreign bodies, loose dentures, anything that can obstruct his airway. Right now, he's awake and alert. What would happen in the next 20 minutes is anybody's guess. Nobody can guarantee how much he has been injured. It could be injury to his abdomen, injury to his pelvis, injury to his chest, injury to his cranium. So right now, he's awake and alert. But in the next 20 minutes, he may lose his airway. He may become unconscious. And if he has a foreign body lying loose or dentures which can slip back, they can obstruct the airway. So always do an inspection of the airway. That's the least you would do to secure your airway. All right? While you are evaluating him for life-threatening emergencies, you notice that the patient's lower abdomen is becoming more and more distended. His blood pressure, in spite of your fluid resuscitation, continues to drop. By this time, the X-rays of his spine, cervical spine, chest and pelvis have been returned back to you for your review. And you notice that the patient has an unstable fracture of the pelvis. Does anyone know what I'm talking about? Unstable fracture of the pelvis? Well, pelvic fractures are of 2 types. Stable and unstable. Simple as that. And if you have a stable fracture, pelvis is like a ring. If the ring is broken at 2 different points, it's an unstable fracture. Or if you have an open book fracture, that the symphysis pubis has opened up like an open book, it's an unstable fracture. If somebody has fracture of the pelvis and is hemodynamically unstable, what is the next appropriate step in the management of this patient's condition? Number 1, the patient should be taken to OR for exploration of the pelvic hematoma. Number 2, an ortho consult should be called. Number 3, patient should be given blood products, including fresh frozen plasma, to correct his hypocoagulability. Number 4, put an external fixator of the pelvis to stabilize the pelvic fracture. And number 5, put up a mast, military anti-shock trousers. What is the principle of managing an open fracture of the pelvis, an unstable pelvic fracture, when a patient is losing blood in the retroperitoneum of the pelvis? OR for what? External fixation requires you to go to the OR. Patient's blood pressure is 90/60 on arrival. 15 minutes later, it drops to 80/40, in spite of giving 2 liters of ringer lactate. After 10 minutes, it drops to 40 or 50/0. What's going on here, guys? You have time to take him to the OR? Takes about 20 minutes to set him up in the OR. What do you need to do? Transfusing. You're transfusing and the blood pressure is going down. Stabilize the pelvic fracture then and there in the ER. Most of these patients can be stable enough to go to the OR. That's fine, but I'm giving you a very unstable patient. You have no time to transfer him to the OR. Before he goes to the OR, you're going to have a dead man on your hand. He's in severe, profound, progressive hypovolemic shock. When a patient is so unstable on pelvic fracture trauma, you need to stabilize the fracture. And for the board, the correct answer is application of a external fixator to the pelvis. So if you have a pelvic fracture that is open, which means that the fracture is opened up, so you apply an external fixator and you close this fracture. So an open fracture is converted to a closed fracture. An unstable fracture is becoming a stable fracture now. Alright? An unstable fracture becomes a stable fracture. Most of the hematomas of the pelvis will respond to this management, and the hemodynamic stability will be reached within a matter of few minutes. If the patient continues to bleed in spite of stabilizing a pelvic fracture, what is the next appropriate step in the management of this patient's condition? Number 1, patient should be taken to OR for exploration. Number 2, patient should be taken to the angiogram for angiographic embolization. Number 3, patient should have a CT scan of the abdomen to evaluate other causes of bleeding. And number 4, to do a diagnostic peritoneal lavage from the infraumbilical incision. That's right. If the patient does not respond to application of the external fixator to the pelvis, don't wait till the cows come home. The patient should be taken to the angio suite sooner than later, because by the time you wait and allow the blood to pick up on its own, and you keep transfusing blood and crystalloids to maintain his blood pressure, what are you doing to your patient? You're basically replacing his blood volume with fluids and packed red blood cells. Fluids and packed red blood cells. What happens to his coagulation factors? Being washed out. So he gets dilutional coagulopathy. And once the patient is coagulopathic, taking him then for angiographic embolization is not going to work. Once the patient becomes hypothermic and coagulopathic, the horses are out of the barn. Angiographic embolization will not work. So you need clotting factors within your circulating blood before your angiographic embolization would be effective. So that brings me to the retroperitoneal injuries. And the retroperitoneum of the abdomen and pelvis is divided into 3 zones. Zone 1, Zone 2, and Zone 3. Zone 1 is the central zone of the retroperitoneum, where you have the aorta, the vena cava, the duodenum, the pancreas. Zone 2 is the flanks, where you have the kidney, the renal pedicle, and the colons, right and left respectively. And Zone 3 is the pelvic zone, where you have the great vessels of the pelvic, the common iliacs, and their external and internal iliac division, and one more important structure in the retroperitoneum that not many people know about. Blood, bladder, kidney. Kidney is not in the pelvis. No. In the retroperitoneum of the pelvis, think about the back. There's sacrum. And what is in front of the sacrum, bounded by a membrane, the presacral fascia, is presacral venous plexus. These are large veins. Presacral venous veins. Presacral venous plexus is extremely vascular structure in connection with the presacral space. And when you have fracture of the pelvis, it is laceration of these veins that causes retroperitoneal hematoma of the pelvis, Zone 3. These veins are not surgically correctable. They are thin-walled, they are juicy, and they bleed rapidly. And they can lose volumes of blood within a matter of short time to cause profound, sudden hypotension. What has happened with your pelvic fracture, once it's open, the veins have no tamponade on it. They continue to bleed in the retroperitoneum, and the retroperitoneal hematoma of the pelvis continues to expand from the bleeding veins till you reestablish the tamponade, which is done by putting an external pelvic fixator. About 85% of all retroperitoneal hematomas arise from the bleeding veins. There is a minority, however, which does not come from the bleeding veins. There may be an injury to an artery, like the superior or the inferior gluteal artery. And when those bleed, they do not respond to your method of external pelvic fixation. Those are the ones that require angiogram and angiographic embolization. Right? What would you do for zone 3 hematomas? Never explore them. They are no man's zone. What would you do for zone 1 hematomas? If on a CT scan after a blunt abdominal trauma on a stable patient, you find that there's a retroperitoneal hematoma in the central zone 1, it's either arising from the aortic injury, vena cava injury, duodenal injury, or pancreatic injury. None of these injuries are compatible with life. They have to be explored. So always explore zone 1. Never explore zone 3. And zone 2 is renal injury. And renal injury is either or. It's either renal parenchyma or renal pedicle. If the injury is to the renal pedicle, the artery and the vein of the renal pedicle system are lacerated and they bleed to exsanguination. They will kill the patient. This is a progressively enlarging hematoma. If you find out that the pedicle is injured, you have to explore zone 2. If it's a parenchymal injury of the kidneys, you don't have to explore it. You can treat it non-operatively. Okay? Now, the diagnostic modality of choice for renal injuries is a CT scan. It can show you whether the pedicle is intact or not. How? If you do a contrast-enhanced CT scan of the abdomen and the kidney is not taking the contrast and there's a hematoma around the kidney, is it a parenchymal injury or pedicle injury? It's a pedicle injury because you need an intact pedicle before the parenchyma can take up the contrast. So if it's a non-enhancing kidney surrounded by a hematoma, on a contrast-positive CT scan, after a blunt trauma to zone 2, the injury is to the renal pedicle and not to the kidney itself. Treatment is OR, operation, and nephrectomy. Otherwise, treat it non-operative. Okay? So zone 1, always explore. Zone 3, never explore. Zone 2, plus minus depending upon parenchyma or pedicle. Simplified form. Don't want to make it too complicated. What are the other injuries associated with the pelvic fracture? Injuries to the urethra, injuries to the bladder, injuries to the vagina, and injuries to the rectum. Out of these 4 injuries, I usually ask about injuries to the urethra. Injury to the urethra, remember that after a pelvic fracture, whenever you have a patient after a motorbike accident who falls from 25 feet into a hard pavement, hands on his butt, and he's got perineal hematoma, scrotal hematoma, or blood at the meatus, or on rectal examination, a high-riding prostate. These are the 4 features. Perineal, scrotal hematoma, high-riding prostate, blood at the meatus. That means the urethra is injured. Should never insert a Foley's in these patients. What is the next step in the management of a patient with blood at the urethral meatus after pelvic fracture? Ureterogram, retrograde ureterogram is the right answer. If the retrograde ureterogram shows you the injury, then you treat it accordingly. That's above the level of step 3. But identify the urethral injuries and pelvic fractures and do not insert Foley's in your initial evaluation. Moving on now to the next case. My foot hurts. That's the chief complaint. This is a 67-year-old man who comes to the emergency department complaining of an acute onset of left foot pain that began 1 hour ago. He denies any history of trauma or previous episodes such as this one. He still has feeling in the foot and is able to move it. The patient has a history of myocardial infarction and atrial fibrillation. He stopped taking his Coumadin 2 weeks ago for unclear reasons. He does not smoke. His only current medication is a beta blocker. On history and physical examination, his vital signs are temperature of 98.6, blood pressure of 120/70, and pulse is 70 a minute. His chest is clear to auscultation, heart rhythm is irregular but without murmurs, and his abdomen is soft, non-tender, and without any palpable masses. Examination of the extremities show bilaterally strong femoral pulses. Pulses in the right popliteal and pedal pulses are normal. Left popliteal and pedal pulses are absent. There is no evidence of chronic ischemic disease in either extremity. These are all crucial points, guys. The left foot is pale and cold to the touch to the ankle. The sensation is intact and there is voluntary motion. The muscles are soft. What are the possibilities of 5P? Pale, pulseless, painful, poikilothermic, and paretic leg. The 5 P's of pale, pulseless, poikilothermic, painful, and paretic limb. The 3 differentials we have here are arterial embolus, arterial thrombus, and sometimes you can get gout. That's not pale and pulseless, but is very, very tender. Initial diagnostic plan, you can do EKG and a chest X-ray. EKG is significant for atrial fibrillation with no acute changes, and chest X-ray is normal. How do you assess these patients? This patient has got a painful cold extremity. Out of the 3 differential diagnoses of embolic occlusion, thrombotic occlusion, or acute gout, how are you going to differentiate one from the other in a patient who presents like that? Well, there are a couple of things you have to note. Number 1, if somebody has thrombotic occlusion, it's a chronic process. These patients have chronic ischemic problems in their extremities. The chronic ischemia of the extremity arises with a history of intermittent claudication first, followed by rest pain if the ischemia progresses, followed by the last stage of ulcers and gangrene. So in the order of progression of chronic ischemia of the lower extremity, it starts off with history of intermittent claudication, progresses to rest pain, then to ulcers, and then to gangrene and loss of limb. This patient does not give you that history. He does not give you history of intermittent claudication. He does not give you history of chronic rest pain, etc., etc., etc. Embolic occlusion is classically presented like this. Patient has cardiac arrhythmias. Majority of the patients with emboli to the lower extremity, the source is in the heart. 70% of the emboli originate from the cardiac chambers. The remaining come from the arteries, proximal arteries, which are diseased. Like aortic aneurysm can embolize the lower extremity, or a popliteal aneurysm can embolize the lower extremity, so on and so forth. The third important cause of acute occlusion of the artery, apart from having an embolus from a cardiac or an arterial source, is trauma. You can have a stab wound to the groin, and you can get occluded artery with no blood flow distally. Or you can have a catheterization for an angiogram of the groin vessel, which leads to intimal dissection and blockage of the blood flow. So all these are causes of acute occlusion. The 4th or the 5th scenario clinically could be a dissecting aneurysm of the aorta, which dissects all the way down to the common iliac artery and occludes the lumen. So these are the 4 or 5 examples of acute occlusion without any history of previous ischemia, like intermittent claudication, rest pain, or ischemic ulcers. When a patient like this comes to you in the emergency room, what is the next appropriate step in the management of this patient's condition? Number 1, order an angiogram immediately, followed by urgent embolectomy. Number 2, patient should be taken to the OR for a blind embolectomy. Number 3, patient should have a duplex study in the ER. Number 4, patient should be observed on IV hydration and heparin drip. Duplex has no role to play in acute occlusion of the artery. In the chronic ischemia, you do duplex studies, not in acute. Heparin? Heparin is the treatment for acute embolic occlusion. What is the critical ischemia time for a lower limb? How long does it take to go dead? 6 hours, not half an hour, 6 hours. It's the 6 hours, it's the study from human, not from human, but animal model, stating that after 6 hours, a lower complete occlusion, acute occlusion of a lower limb vessel will lead to limb ischemia, irreversible limb ischemia. Okay? So if the patient comes to you within the next couple of hours from the onset of pain, then you have time to do an angiogram, And the right thing to do in this case, which arrived within 1 hour from the onset of pain, is to do an angiogram, because you have time to do an angiogram, you get a roadmap, and then you operate. What do you find on an angiogram in acute embolic occlusion, and what do you find on an angiogram if this was a chronic thrombotic occlusion? Silence with no answers. It's a sudden, sharp cutoff point in an otherwise healthy vessel. There's no disease, there's no atheroma, there's no stenosis, there are no collaterals. Sudden, sharp cutoff point of a vessel, in a vessel, is an embolic occlusion. If it was a thrombotic occlusion or a chronic occlusion, the disease will be generalized in the entire limb arteries. There will be multiple areas of stenosis. May not be critical stenosis, but there will be atheromatous plaques all around seen on an angiogram. There will be multiple areas of collateral vessels open around the obstruction. So there's a major difference between the two on angiography. Clinically also there's a difference between an acutely ischemic limb and a chronically ischemic limb. An acutely ischemic limb will have a normal looking skin. Hairs in the skin will be normal. There will be no atrophy of the muscles. In a chronically ischemic limb, the skin is thin. It's atrophic. The overlying skin hair follicles are gone because of atrophy from chronic ischemia. And the underlying muscles in that limb are also atrophic because of poor circulatory status. And the nails of chronically ischemic limb will show hypertrophy, hyperplasia, and chronic infections, fungal infections, onychomycosis and onychogryphosis. You don't have any one of that in this patient. And the classical history of somebody on atrial fibrillation, Coumadin should be on board 24/7. And when the patient does not take Coumadin, is non-compliant, he pays the price by having an embolic occlusion like that. That's a classical scenario for the board. The classical scenario for the board will also come in other situations where you see an acute embolic occlusion anywhere else in the body. It could be a mesenteric infarct like that. Okay? So just not the limb, it could be the abdomen as well. So the right thing to do here would be to do an angiogram and do an embolectomy in the OR after the angiogram. If this patient arrived after 4 hours from the onset of symptoms, all you've got is 2 hours before you develop critical ischemia. In such situations, waste no time in doing an angiogram. Do a clinical diagnosis of an embolic occlusion if it is clear to you, and take the patient to the OR and do an embolectomy and on-table angiogram at that point in time to save time. So you have to ascertain whether the patient arrives early enough to allow you to do an angiogram. So preoperative angiogram followed by embolectomy is the best answer if you have time. If you have no time and the patient arrives late from the onset of his symptoms, please do not waste time doing an angio. Save this man's leg. Another case scenario. Patient is a 25-year-old man who comes to the emergency room after 18 hours of sudden onset of severe pain in his right lower leg. On arrival, his leg was pale, pulseless, painful, paretic, and poikilothermic, that is cold. Right? In such a situation, you examine the patient and you notice that the patient's skin is cold. The color of the skin is gray, and there is mottling which is fixed, does not blanch with your pressure. He does not feel you touching him. He is incapable of moving his toes and flexing his ankle. And he has tension in the compartments of the muscles under question. The next appropriate step in the management of this patient's condition is, number 2, do an emergent embolectomy and fasciotomy. Number 2, do an angiogram and angiographic placement of a TPA catheter for thrombolytic therapy. Number 3, patient should have an amputation of the leg. And number 4, patient should be started on heparin and re-evaluated after 6 hours. Embolectomy and fasciotomy. Most will appeal to that. Agreed? Wrong. Wrong answer. Amputation. Who says amputation? 25-year-old man, amputate his leg? He hasn't even started his life. But that answer is correct. That answer of amputation is the right answer for the board. What kind of a leg have I described to you? I have described to you a dead leg. It's not a ischemic leg, it's an infarcted leg. Please remember the definition of ischemia and infarction. You have to differentiate between those that will die and those that have died. There's a difference. If a triage from a multiple trauma scene brings about 5 patients, one is dead, others are about to die, where are you going to focus your interest on? Those who are dying or those who have died already? Similarly here, no. Those who are dead. You can't change the course of fate out there. Similarly, this man has sat for 18 hours on a completely occluded vessel in his leg, and he has arrived when the ischemia has advanced to infarction. And the signs of infarction are, number 1, he has paralyzed leg. He can't move it. Paralysis is a sign of death. Secondly, his skin changes are not pale, but he has got grey-looking skin. If the skin is cyanotic and greyish and is mottled, and the mottling is fixed, that's a sign of death. And 3, if the patient has no sensation, so he's neurologically totally gone, he has got no sensory or motor function left, and his skin has got fixed changes, that is death. That is infarction of the leg. Now, what about being sympathetic to him and try and save his limb? And let's see if we can just do an embolectomy and see what happens. If it doesn't work out, we'll take it off. What's the big deal? Why am I making a big deal about not even considering an embolectomy in this patient's case? Yes, we are talking about reperfusion injury, guys. Once you reperfuse an infarcted leg, the blood that's going to return back to his general circulation is going to be rich in what material? It's going to be rich in cardiotoxins and nephrotoxins. Examples are, he will develop myoglobinemia, which is nephrotoxic. Myoglobinuria will lead to acute renal failure. Secondly, his blood will be rich with potassium and oxygen-free radicals, which are cardiotoxic, which will lead to arrhythmias of such severe nature that no medication or electric shock can bring the patient out from his arrhythmias. These patients code on the table and die on the table. So the moral of the story is to save this man's life, not his leg. You have to sacrifice the leg. The important point here to remember is he's 25 years old, healthy guy with no history of IVDA or any other risk factors. Where did he get his embolus from? Did you guys think about that? He didn't have any crush injury. Did I give you crush injury? No. He walked in. Huh? I told you I did not give you any history of drug abuse. When would you get a young man or a woman who walks in with an ischemic leg, with no predisposing factors, no murmurs, no arrhythmias, no hypercoagulable states? You must, if this patient had arrived earlier on, you must, and even now, this patient's leg should go into the pathology department. They should remove the clot in his vessel and examine the clot for one entity. What is that? Nobody gets me that answer. Myxoma of the heart. When you get an left atrial appendageal myxoma, it embolizes. That's what it does. It breaks and embolizes and produces spontaneous ischemia. Please always do your embolectomy and send the specimen to pathology to rule out myxoma. Because once you find the source, then you have to treat it before it breaks again and creates another embolic occlusion somewhere else in the body. Remember, that's important. Okay, we have done this. After immediate heparization, you do an arteriogram and you see a cutoff point, so you do an embolectomy. and we discussed this case. Case review. Done that. The next case. Chief complaint, right upper quadrant pain. History. A 33-year-old woman comes to the emergency department complaining of increasing right upper quadrant pain that began earlier in the day. She has fever and chills and has an episode of emesis this evening. She has had similar type of pain in the past, however, never this severe. It is typically associated with bloating after eating fatty foods and is sometimes accompanied by anorexia. The attacks usually last a few hours to a day. She denies jaundice or a change in the color of stool or urine. She is a well-appearing female in mild distress. On physical, vital signs show a temperature of 101 degrees Fahrenheit, a blood pressure of 130/70, and a pulse rate of 105. Her skin is non-icteric, that is not jaundice. Her heart and lung examination is normal. Abdominal examination shows marked right upper quadrant mid-epigastric tenderness with rebound and some mild guarding. No discrete masses are palpable. The peritoneal signs seem to be localized to the right upper quadrant. Rectal examination is unremarkable. Pelvic examination is unremarkable with no bleeding or adnexal masses. What is the differential diagnosis of pain in the epigastrium right upper quadrant region? The first and foremost, especially if your patient in the scenario is a female who is fat, 40, flatulent, fecund, fertile with 45 children. Think about gallstones. The most common cause of right upper quadrant pain is gallstones. Gallstones are very common. The disease of gallbladder is very common. So you must think about gallstones as a number one in your differential diagnosis. Okay? Number one is acute cholecystitis, which is a complication of gallstones. We'll talk about that. Number two, cholangitis, which is infection from the biliary tree associated with mostly gallstones. We'll talk about that. Pancreatitis. Most common cause of pancreatitis in this country is alcohol. Second most common cause is gallstones. And as they say, if it's a female suffering from pancreatitis, you should hang her upside down till you find a gallstone, because the most common cause of gallstones in a female in reproductive age is still gallstones. Peptic ulcer disease, present with epigastric, sometimes right upper quadrant sign. Viral hepatitis and perihepatitis. Appendicitis can be confused with acute cholecystitis depending upon the location of the appendix or distension of the gallbladder down towards the appendix. And ectopic pregnancy can present with right upper quadrant signs and symptoms. And renal colic is always in the differential diagnosis of gallstone disease. Now, my question here is, this is the case scenario in front of you. The patient comes in with the history that I mentioned, and the board is going to ask you this question: what is the next appropriate step in the management of this patient's condition? And the choices will be, number one, do an ultrasound of the abdomen. Number two, do a HIDA scan as the next step in the diagnosis. Number three, patient should get a CT scan of the abdomen. Number four, patient should have a laparoscopic evaluation of her abdominal pain. And number five, patient should be sent home on oral antibiotics and analgesics with follow-up in 1 week. Ultrasound has become the standard of care in evaluating any patient who gives you the history suggestive of gallbladder disease. It is one of the best tests that the board wants you to know and pick. It's cheap, it's non-interventional, and it's very, very sensitive and specific for gallstones. Okay? An ultrasound was done and the patient did not have any gallstones. Well, you have to consider the differential. Could it be pancreatitis? How would you differentiate that? A pancreatitis is diagnosed by, number one, pain is in the epigastrium but also general. It's not localized. This woman has localized pain. Secondly, what is the gold standard of diagnosing pancreatitis? Serum amylase and lipase are elevated. It's a biochemical diagnosis. You can confirm that by doing a CT scan of the abdomen in pancreatitis. So this patient does not have amylase lipase elevation, and if you do a CT scan, you will not find anything. Second, third, peptic ulcer disease, epigastric pain, right-sided pain can happen, but there's a classical symptomatology complex of peptic ulcer disease. Pain is associated with meals if it is a gastric ulcer, and if the patient goes hungry, wakes up in the middle of the night at 2 a.m., goes to his fridge, opens up the door of the fridge and drinks a large glass of milk with 2 nice homemade cookies that his wife made a day before. And he does that every day. That's a duodenal ulcer. Pain happens when the patient is empty, which happens when you're sleeping because you can't eat. So you get up and you eat and you put on weight. That is duodenal ulcer disease. Okay? And what's the gold standard for diagnosing peptic ulcer disease? Somebody presents to you with a suspicion for peptic ulcers is endoscopy will confirm the diagnosis of presence or absence of ulcers. Viral hepatitis or perihepatitis can present with right upper quadrant tenderness, fever, leukocytosis. But the history will be different. Patients will have altered LFTs. In a simple acute cholecystitis or a biliary colic, LFTs are usually normal. The LFTs in viral hepatitis are particularly high in which range? The bilirubin will be high, the direct will be high, the alkaline phosphatase will be high, but it is the transaminases, which will be in thousands, that will give you the diagnosis of hepatitis. You can send for a hepatitis panel, and the patient will get positive hepatitis B or C, or non-A, non-B, non-A, non-B, or non-C. Okay, so you send out for hepatitis panel. The third thing that you have to consider in the differential is appendicitis. Sometimes patients have an appendix sitting high or retrocecal appendix bursting in a higher position than the McBurney's point, and they can be confused. The pain is neither in the right upper quadrant nor in the right lower quadrant, but in the gray zone. Yes, appendicitis is in the differential of acute cholecystitis. Similarly, an acute cholecystitis can mimic appendicitis. The gallbladder distends and goes down into the right lower quadrant region, and you can feel pain in the right lower quadrant as if it was an appendicitis. But the history of appendicitis, as we discussed first thing in the morning, was classical. Pain starts in the central abdomen and then shifts to the right lower quadrant, associated with anorexia, nausea, and vomiting, and patient doesn't usually give the history of similar episodes of pain in the past, whereas acute cholecystitis usually comes with a history of biliary colic from the past. Ultrasound of the gallbladder will rule out gallstones, and then you can think of appendicitis. And similarly, you can also think of appendicitis if you are in doubt, do a CT scan. It's very diagnostic of appendicitis in adults. More than 95% accuracy on CT scan of the abdomen. Ruptured ovarian cysts, ectopic pregnancy, mostly pelvic pain, and that usually doesn't mimic renal gallstones. Renal colic, pain starts in the flank, radiates down to the groin, associated with hematuria. This woman did not have pain like that. She did not have hematuria. The diagnosis of renal colic can be confirmed on the basis of doing a plain X-ray showing a radiopaque shadow in the line of the ureter. But the most sensitive diagnostic test available to us today to confirm a ureteric colic is a spiral CT scan without contrast. A spiral CT scan of the abdomen without contrast has now become the most sensitive test for ureteric colics. So ureteric colic, classical history, radiation to the groin, hematuria, spiral CT confirms the diagnosis. Now, I told you that this patient presents to you with a classical history of a renal colic. right? Now, when history of an acute cholecystitis, I apologize. And you did an ultrasound should show you gallstones. And if they show you gallstones, no problem. But if they don't show you gallstones, and the history is very good, the pain is in the right upper quadrant, radiates through to the back, radiates to the tip of the shoulder, associated with nausea and vomiting, associated with fatty meals, in a fat, 40, flatulent, fecund, fertile woman with 45 children. What have you got? You've got gallstones unless and until proved otherwise, guys. And although ultrasound is a very good test, it's only 95-96% sensitive, it's not 100%. So what is the gold standard for diagnosing an acute cholecystitis? HIDA scan. And then the board is going to ask you what is the next step. You will pick up HIDA scan as your answer. Because HIDA scan is a radionuclear scan. The dye that you inject in HIDA scan in the radionuclear suite is actually concentrated by the liver and excreted into the biliary tree. Now, in the biliary tree, you will see the entire intrahepatic biliary tree and the extrahepatic biliary tree, which includes the gallbladder. If you don't see the gallbladder on HIDA scan after 4 hours, what does it mean? What does it imply? It implies what? Either the gallbladder has been removed or it is obstructed. By what? By a stone. Sometimes a stone can be so small in sitting and impinging upon a small cystic duct. That is all it takes to cause acute cholecystitis. And HIDA scan will pick that patient up. Okay, so it becomes a gold standard for diagnosing acute cholecystitis. This is the diagram of the biliary tree. All right. The two hepatic ducts join to form a common hepatic duct, which joins the cystic duct to form the common bile duct. The common bile duct drains into the second part of the duodenum in combination with the pancreatic duct. The gallstone here in the gallbladder is classically seen in females, fat, 40, fecund, and flatulent females. Why? Because of the excessive estrogen, it produces supersaturated bile. Cholesterol gets excessively saturating the bile, leading to deposition of the cholesterol crystals, leading to formation of the nidus for the gallstones. So more pregnancies you have, the more the risk of gallstone formation for two reasons. Number one, it causes supersaturation of the bile, and number two, it causes stasis because progesterone causes relaxation of the smooth muscles in preparation for the protection of the embryo from getting aborted. So the effects of progesterone are systemic, and all the smooth muscles of the body are relaxed in pregnancy. And when you have a relaxed gallbladder, it has a high risk of forming gallstones. That's why you see gallstones in vagotomies as well, because vagus nerve causes contraction of the gallstone. When you do a truncal vagotomy, innervation to the gallbladder is gone. Gallbladder gets paralyzed and has a higher risk of developing gallstones. Same mechanism, but different etiologies. Got it? So once you have a gallstone, majority of the gallstones are asymptomatic. They say 30% of the global population has gallstones, but not all of them know they have it. Many die with their gallstone within them without them ever knowing about it. The first symptom of gallbladder disease is a biliary colic. Once you get the biliary colic, the patient has a classical symptom. Pain comes in the right upper quadrant, goes to the back, associated with nausea and vomiting each time the patient eats a burger or fries or anything fatty. The pain comes and it goes. Crescendo, decrescendo. Crescendo, decrescendo. These are biliary colics. They don't stay there. Patient has no leukocytosis, no fever, no tenderness. It's just pain. Comes and goes. Would you operate on this patient? Absolutely. It's a symptomatic gallbladder disease. Any gallbladder that is symptomatic needs to come out. Second, cholecystitis. If the pain does not go away and persists because now the stone is impacted in the cystic duct, the patient presents now with a history previously of biliary colics, now the pain doesn't go away. She says, She takes all the painkillers, it's not going away. In fact, when you palpate her, the abdomen is tender. It's got a classical Murphy sign, which means pain on deep inspiration. That's classical for acute cholecystitis. There may be fever, there may be leukocytosis, there may be tachycardia, all the signs of peritonitis. Now, what has happened is an obstructed gallbladder has now become infected. And the treatment for an acute cholecystitis is, if the patient presents within the first 3 days from the onset of pain, laparoscopic cholecystectomy emergently. If the patient presents after this window of opportunity is gone, admit NPO, IVI, IV antibiotics, close observation to make sure that the gallbladder cools off. Then rebook the patient 6 weeks later for an interval cholecystectomy. However, if the patient's pain persists or gets worse, or fever, or leukocytosis, or any of these values progressively get worse, you have to do an emergent cholecystectomy. The emergent cholecystectomy is most likely going to be an open operation, not laparoscopic operation, because chances of success doing laparoscopic cholecystectomy in acute cholecystitis that has gone beyond 3 days is less. However, you will attempt it, patient's condition permitting. 3, if the cholecystitis is not resolved and the patient's stone remains impacted, then the next step is mucocele of the gallbladder. This is the complication of cholecystitis. Mucocele basically means the bile has been absorbed by the lining of the gallbladder, but the gallbladder is filled with the mucus now from the goblet cells lining the epithelium of the gallbladder. And this is acute neglected cholecystitis, mucocele. Treatment is the same, surgical. Number 4, once the mucocele gets infected by bacteria, this whole bag of gallbladder gets converted into a bag full of pus. That's empyema of the gallbladder. Bag of gallbladder filled up with pus is called empyema of the gallbladder. These patients are now progressively getting worse clinically. Once you don't relieve the empyema surgically, it's going to progress into gangrene of the gallbladder. That's how it's going to progress. It will become gangrenous. There will be air in the wall of the gallbladder. On a plain abdominal X-ray, you will see air deposits within the wall of the gallbladder, and that's a bad sign. Somebody who is sick, who has air in the gallbladder wall, he needs to get emergent cholecystectomy or he will die from perforation. So the 6th problem is perforation of the gangrenous gallbladder leading to biliary peritonitis, which has a high mortality rate. A free perforation of a gangrenous gallbladder into the peritoneal cavity causes biliary peritonitis, and 30% will die from this ailment. 7. If you have a situation where there's a large stone sitting in the fundus of the gallbladder, then it erodes chronically and fistulate with either the duodenum or the colon, leading to a fistula between the biliary tree and the gut. This is known as cholecystoduodenal or cholecystocolic fistula. That's called chronic perforation of the gallbladder. This will lead to another complication which is known as gallstone ileus. Mechanical obstruction of the small bowel from a large stone of the gallbladder that has tumbled its way down through the gallbladder fistula with the small bowel and gets impacted in the point of narrowest area of the small bowel, which is the terminal ileum or ileocecal junction. Okay? Can you, on a plain X-ray, diagnose a gallstone ileus? Is a gallstone radiopaque or radiolucent in majority of the cases? It's radiolucent. Can you diagnose on a plain X-ray a gallstone ileus? You can. If you see multiple air fluid levels in a distended abdomen that is behaving like a obstruction, and there is no other evidence of obstruction or cause of obstruction like previous history of surgery or external hernias, the patient has a simple obstruction and there is air in the biliary tree on your X-ray. You do an X-ray, and what you see on an X-ray is, oh, look at that, multiple air fluid levels on a virgin abdomen. no hernias, no previous surgeries, multiple air fluid levels, and there is air in the biliary tree. You've got a surrogate sign for gallstone ileus. That's another complication. 9 is pancreatitis. 10 is cholangitis. All these are complications of gallstones. We'll talk about cholangitis briefly after the lunch break. All right? We'll take a lunch and be back here at 1 o'clock.